Welcome back. And this is the first of two parts in our role in imaging. And this first one is deciding when and what to order. A patient presents to physical therapy, and there's a couple different scenarios. One, they may already have imaging, and how do we correlate this information into our exam and management decisions? Or secondly, there's no imaging yet, and we needed to determine if there is a need for imaging. Again, just like if we're determining if this individual is appropriate for physical therapist care. So what does imaging do? Well, imaging allows for a more comprehensive exam when it's needed, when it's clinically indicated. Many evaluation tools are subjective and questionable diagnostic utility. And even though we try to put as much objectivity into these, such as with Lachman's test, varus valgus, shoulder test, etc., there's not a lot of data that substantiates many of these tests. And if there is data, it doesn't often relate well to many individuals across the population, because the defining criteria of those tests are very specific. And so we have to apply the measurements within our population and do some extrapolation, a little bit of reach out there, but we often are left with some areas of uncertainty. Also, imaging is ordered when we have that expectation that a positive finding will influence decision making or require a change in typical management. I suspect a fracture. Right now they are on crutches, maybe a splint, and we get x-rays, finds the fracture, changes that we need to cast it or surgery or something else. So it's going to add additional levels of management into this person, this individual, if we find what we expect to find. Secondly, it's an added dimension of anatomy. We can look at things. It's two-dimensional in many imaging, but because we get two-dimensional pictures, we can put a three-dimensional framework in there. We're also now getting three-dimensional CT scans that are used in really capturing fractures, how they can plan for surgery or other organs and tissues three-dimensionally. So this is expanding, but it gives us a different perspective, a different look of anatomy. And we may find this information is different than what the physician receives. The physician may say there's a fracture here and here, or here's an ACL tear, I need to go and do surgery. We may look at the joint and the way maybe some degeneration is there, or how the screws are placed, etc. And we can use this information to influence our management. So a few key elements here about imaging. First of all, know your scope of practice. And I'm not just talking about your scope within your PT Practice Act and the scope that that provides. What is your personal scope? What is your knowledge that you have and experiences that you can then apply? How do you plan to grow your knowledge and experiences to be able to do more for patients when you face times that I don't know, I don't have an answer, how can I study up and prepare myself? So we have the legal side, but we also have our personal scope, that if we go beyond our personal scope on our own competencies, then that can set us up for some legal issues as well. Learning to determine when imaging is, and also importantly, when it is not needed. How we can integrate findings from imaging into our plan of care. And how do I understand an image and the report as I gather relevant information? How about the modality? We need to know which modality to use. What type of tissue is hypothesized to be at fault? And what am I looking to find? How am I looking to show through the image what my hypothesis is. And even though I start with plain films at first, that may give enough of an answer. But if not, then what is the right film or right modality to use to get imaging? Is this person able to do that modality? MRIs use very high strength magnetic fields. If they have metal implants or foreign objects of metallic nature, they're not a candidate for MRI. If they're claustrophobic, maybe there's ones that have more of a narrow opening tunnel, the older type MRI that's still being used, maybe they can't be there because of they're claustrophobic. CT scans have high amounts of radiation. Maybe this is someone that we want to prevent radiation use because they've had other imaging. We need to go to a different mechanism. So there's lots of decisions in figuring out what type of modality we want to use. And then we have to communicate this information with the radiologist, maybe their family physician, also the patient or other providers too. So we touched on this briefly on this past slide. Each of these primary modalities for imaging have different purposes, and we'll cover each of those as we get to the purposes in the specifics for these modalities. But suffice it to say that they don't duplicate, or they should not be used just to duplicate. They should be used to go deeper than plain films in each of these into the various aspects that we're looking for patients. So again, imaging is indicated when the information that it would yield in a positive finding will change the treatment plan. And that's an important component to remember here. So we don't just do imaging just to be, well, let's just see what's going on. We often hear that patients come to us, back pain, no leg symptoms whatsoever. Physicians like, yeah, let's get x-rays to see what's going on there. That shotgun approach isn't really beneficial and can maybe more harmful to patients and run people down different lines of care and visits and cost and imaging exposures, and not to mention the frustration and mental anguish that can come on. So how do we decide what to order that is best utilized? And there's several tools that we can use that are some clinical decision aids. It's nice when things are there to really help you. And so the first one could be just decision rules, such as the Ottawa knee and ankle rules, the Canadian C-spine rules, or the Nexus rules for neck pain, neck trauma. These are evidence-based, and they help to determine a level of risk where we get imaging on folks, we can really not miss the serious conditions. Again, imaging isn't foolproof, and risk levels are determined off of statistics, and statistics are based off of numbers and averages. But we want to try to elevate the quality of these rules to where we're not missing at least serious pathology. So these decision rules are one. The second, and we've mentioned it in our first session, is this American College of Radiology appropriateness criteria. And these are evidence-based consensus with physicians, radiologists, going through applying the evidence, and often many of these decision rules that we just mentioned to really get a expert consensus opinion about what's the best modality based on certain patient presenting characteristics or presenting findings. And then there's times we'll have uncertainty. Discuss with the primary physician or specialist. If you're ever unsure what to order or recommend, just say, hey, advanced imaging is needed, or advanced investigation. We need to look at more. I'm not sure what yet, but send that back to the specialist, or defer that decision to somebody else versus just ordering just for the sake of being able to order. We don't want to get into that business either. So as mentioned, there are several decision rules that have been established, and you may be familiar with some of these, if not all of these already. A lot of these are written for people who have acute injury, like right away within the first 72 hours of an injury or event, and they present to an emergency room. These are not written for someone who presents to PT with chronic back pain that's been there for 8 months or 10 years, okay, or neck pain from sitting at a computer just doing work but no type of trauma. We have to make sure we look at the population and the intent of these rules if we're going to apply them to meet the rules or not. Some people with non-traumatic pain, such as neck pain, will go in and say meets the rules in their note or does not meet the rules. Of course they're not, because it's different, a different situation. So we'll need to be mindful of why we have these clinical decision rules, and so when they're best utilized to answer the questions they were designed to answer. This American College of Radiology appropriateness criteria is probably the most valuable component that we have, this most valuable tool we have to use to apply imaging. And I would encourage you to bookmark the site. It's acrsearch.acr.org/list. And if you go to that link, it'll take you to this. And what I've done here is I've already gone under panels and selected topic for musculoskeletal, and then it'll take us to different topics within the musculoskeletal realms of these criteria, so we can look at the narratives and rating tables and understand what may be the best modality per a clinical variant. So let's dive into that, and I encourage you to go explore this on your own. A few other things to look at and notice here are in here we have not only a narrative and rating table, which talks about it, but there's evidence, and that's going to be the main thing we're going to look at. But there's also evidence tables, lit searches, and some of these even have nice patient summaries and in patient language that can be provided to help understand, and maybe for you to explain to a patient why they're getting recommendations for certain types of imaging modalities. So for example, let's say we have a patient who has an acute trauma to the ankle. They were playing sports yesterday, today, rolled their ankle. You see them either in your clinic, direct access, maybe you're working in a hospital and the ER called you down to take a look, or they went to their family physician and the physician said, hey, you know what, I really think you need to see the PT on this. You guys have offices, maybe in very close proximity. They bring the patient over to you and you take a look, and you're like, I'm doing my exam. They seem to have some acute tenderness, and they aren't able to walk. They might need imaging. Let me see what the ACR guidelines have to say about this. So you pull up the ACR guideline that talks about acute trauma to the ankle. And once you pull this up, you go and you select the narrative and rating table. And this is what pops up here on the right-hand side of your screen. Now, on the left here, I put the auto anchor rules because this is something that we're familiar with in using here, and it has areas of tenderness. For example, the posterior area of the malleolar. We have the navicular area, etc., the inability to bear weight. So we have some criteria already, but what's the first imaging that we want to take? Well, there's several options here in this imaging table, and even within this table it talks about our variant. And so variant 1 is an adult or child 5 years of age or older, acute trauma to the ankle with persistent pain for more than a week but less than 3. And so you notice here it's acute right away, or they've had this persistent pain. So they give you two variations here within this variant. Nothing exclusionary is present, and so for initial imaging, and the patient meets these of the Ottawa rules, radiographs, usually important. A fair amount of radiation here, but nothing else is appropriate at this point. Let's start with radiographs to initially determine what might be going on that's preventing them from bearing weight, maintaining this this sense of tenderness and pain with palpation, etc. So if the same case, well, what if that the radiographs demonstrated a fracture or potential osteochondral injury, and they wanted to get more information? What can we do then? Well, we can go to the variant 5 here within that same acute injury to the ankle, and in variant 5, some findings on the radiograph, but let's look at further investigation. We know that an MRI and a CT, both without contrast, would be appropriate. When would I choose one over the other? Well, MRIs take time. They are a much longer duration study if anybody's had an MRI, but there's no radiation. CT scans can be very fast, usually in and out of those within maybe 5 to 10 minutes, but there is radiation with those. And so it depends on what is being looked at. Why are we doing the MRI or CT? If they're a surgical candidate, I'm not going to be the one that's going to order these. I'm going to defer that to the specialist who's going to do the surgery, because often they're going to want their own imaging and to look at those and to have their spin on what is needed. So we have to be mindful of what's the next step in a patient as well. But to suffice it to say that this ACR helps to create variants based on various scenarios and to help determine what are the next studies in a sequence to be able to eventually get to that point where we can now initiate the treatment that this individual most appropriately needs. Now, what about someone here with chronic ankle pain? Ankle radiographs are normal, suspect a chondral lesion, and so there's a chronic ankle pain topic that we can use. And if they get to this chronic ankle pain, radiographs are normal, and we think they may have a suspected osteochondral lesion. And there's certain ways we can look at that. Maybe they have limited dorsiflexion, point tenderness over the talar dome. Maybe there's some pain within a certain part of the gait cycle or ankle movement in weight-bearing activities. Well, we can go here and we can look at options. And if we're looking at soft tissue, then MRI is the best modality to use. CT could be appropriate, but it's not going to show the soft tissue chondral area like MRI would. Again, CT is very much based off of radiograph technology. MRI is going to look at different types of tissue structures better to meet this hypothesis that we suspect an osteochondral injury. So I encourage you to take some time to look at the ACRs, go in and just play around on that website and look at back pain, look at shoulder, look at the different variants that you see on there and get some familiarity, because this will be a great tool to use not only if you refer for imaging, but if you just recommend or point somebody back to this is your recommendation and substantiate your position, but it helps to solidify your clinical exam also. So in this session, we spent some time talking about some of the roles of the PT with imaging and also using a couple of the tools to integrate our exam findings to help understand what is the best modality to use when imaging is indicated in a patient. Take a short break and then come come back to part 2.